Okay, we are live. I will be joined momentarily by Dr. Gallus, and we are talking about breast augmentation again today. It's one of our favorite surgeries, both of us. And we're going to talk about the actual day of surgery and what happens, what you can expect. There may be children walking around behind me. It's cool. We're letting them stay up later. We're seeing how that works. And cool, here is trying to find Cat and add her. There we go. She's on the Restore Plastic today instead of the Cat Gallus MD account. But we'll get her on here and we'll talk about some breast augmentation, which I think I saw 2 or 3 breast aug patients today in follow-up, maybe 3 or 4. It was a lot. Anyway, it's nice to see everybody and see how they're doing. All right. Okay, maybe she went back on the other account. Oh, hey, my 7-year-old is here. He just made his first batch of scrambled eggs all on his own. So that's pretty exciting. Okay, here's Dr. Gallus. Okay, if the table's shaking, it's because he's currently climbing on it. Hey, how are you?
Hey, good. Let me sit down. Whoa.
Yeah.
Okay. Let's see. I'm good. How are you?
I'm good. I'm sitting next to my 7-year-old who just made his very own first batch of scrambled cheesy eggs all by himself. So,
Ooh.
pretty awesome.
Anything that's so nice when they're able
Yeah,
to cook
nothing's on fire. He added cheese to them. He cracked them. He did good.
That's awesome.
Yeah.
So, did you have a good 4th of July?
Yes, it was hot in Cleveland, so we swam a lot. And then we actually got to watch the fireworks out our bedroom window. The country club down the street was having fireworks. It was awesome. How about you?
That's nice.
Yeah, it was very convenient. We were in our jammies.
Yeah, we're lazy about the fireworks too, so we can watch them from our balcony
Nice.
over the San Diego Bay. So we just roll up, and then we're like, "Is it
Nice.
over?" Because I want to go back downstairs.
Yeah, it's like
cold.
it's not comfy. Oh,
Yeah.
cheers. Yeah, we had to stand at the window. It was very hard.
Yep. Yeah, I was like, oh, I do not miss the days of having to drive somewhere.
Oh, I remember as a kid, like all of the traffic, and we would park at my aunt's house because there was no parking around the lake. I don't know. It was fun when you're a kid. It's less fun as a mom.
Yeah, when you're driving and hauling all that stuff around.
Yeah. Yep. And as a plastic surgeon, of course, with all the burns with the sparklers, I'm so paranoid about those now.
Oh my gosh. So many, so many 4th of July call weekends. And
Yep.
that I want to think about.
I don't miss that at all.
Yeah. Are fireworks legal in Ohio or?
Oh yeah. They sell them
are?
at the grocery store. Mm-hmm.
Yeah.
Yep. But I haven't done hand call in years, and now I don't do ER call at all. So I am blissfully out of that.
Yeah. Same.
Yeah.
For some reason, I can't actually see you. It's really weird. I guess
That is weird.
But I can hear you, so I guess that's good.
I can see you. You look great.
I was in the OR today doing the opposite of what we're going to talk about. So I was doing a breast reduction.
Nice. It's funny. I think I do almost as many reductions as I do augmentations. It's maintaining balance in the universe.
Yeah. It's the yin yang of what I do, for sure.
Yep.
So, but we were going to talk about breast augmentation the day of and beyond, right?
Yeah, like what the whole process is like, and then recovery, and all the good stuff. It's like not as bad as people think. I find. I mean, I haven't had breast augmentation, but from what my patients tell me, it's just not a terrible recovery.
Yeah. I feel like I've seen practices where they tell people to you're never going to be able to sleep on your stomach again. Don't raise your arms above shoulder height.
Oh yeah,
for 2 weeks.
That's a big one. And I always tell people the exact opposite. Like I want them stretching like this to stretch out their pecs.
You want to put your arms over your head.
Yeah.
Yeah. I was like, no, wash your hair and do those things. What I don't like people to do is for the first couple of weeks is, decide to move a bunch of stuff over their cabinets or push. I think I say it's funny. You're not going to mow your lawn or vacuum the carpet, but literally no one in San Diego mows their own lawn, so it's never an issue. but that kind of, push pull, have a big dog that you're walking. And you're not
Right.
going to push on your chest in an abrupt manner, but I don't want you to be like this, because then your shoulders are going to get, stiff. So you want to move
Yeah,
around.
absolutely. Yeah, and it's, obviously with a bigger implant, it feels tighter, especially if it's
Mm-hmm.
under the muscle as opposed to above. The
Mm-hmm.
women who do a smaller implant, they're like, man, that was kind of a breeze. My patients who go with the 600, 700, 800 cc implant, they feel a little more like they got hit by a truck for a week, and that's okay. I tell them
Right.
to expect that, and they generally do just fine.
I remember when I first started, we'd say, oh, and this might have been because I did some of my training in Indianapolis. Oh, it feels like you in the Midwest, you got kicked in the chest by a horse. But I think
Yes.
that is more
Oh,
in
well, then I
line.
know what that does feel like.
Oh, you
That I've
do?
done. That I've done. Yeah.
That's hilarious. Yeah,
Yeah.
I do not know what that feels like, but I think that goes with the larger implant. But I
Right.
also did work with Bruce Vanetta, who's still practicing in Indianapolis, who does a lot of augs, and he had the recovery plan where the patients had to do jumping jacks in the recovery area, and he only gave you Motrin, and you were supposed to go back to full speed a couple days later. So I feel like there's the people who are like, we're gonna put you in bubble wrap and in a medicated coma for 2 weeks, and then be like, we want you to do some push-ups before you leave, and you're like, no, that's
Yeah,
so
let's
yeah.
not do
It's
that.
interesting. Yeah, no, I don't want. So I can't imagine making someone right after anesthesia get up and do jumping jacks, but that was part of his deal. And there are people who
Wow.
talk about going back to work or going back to whatever just a couple of days afterwards. I think, as usual, the extremes are probably not realistic and work for a small amount of people, but
Yeah.
I
Yeah, I've
think
had a
they're
couple
ongoing.
people go back after a few days. I tell most people, take a week. You've had surgery. You need to recover. That
Right.
said, I have found recovery's gotten a lot improved as I started doing the ARIS protocol, which is enhanced recovery after surgery. And I don't know if you do some or any of
Mm-hmm.
that, but yeah, so doing anti-inflammatories like Celebrex the night before, and then combining non-narcotic pain medications. I do PEX blocks with all my breast surgery, which is
Okay.
nice. We have an ultrasound available in the OR.
Nice.
And that really helps. I've had several patients do AUG and even AUG and mastopexy and not take any narcotics because they just didn't really need them and didn't really want to because the constipation and the nausea weren't worth it.
Yeah, I do. I do Mobic or Celebrex the night before, Tylenol the morning of. I
Mm-hmm.
do put a ton of Marcaine in there. I don't have an ultrasound to do a formal block. And
If you
then
ever want one, though, get the butterfly. You can do
yeah.
PEX blocks with those. Yeah, I've been using it in my office like crazy since I got it a couple weeks ago, and you can definitely do PEX blocks with it.
Oh, really? Oh, yeah, that's
Yeah.
good to know.
Yeah, I mean, you
Can
could bring
you
it to
do,
any OR.
so with that ultrasound, can you see facial anatomy for filler? Because that's my
I think so.
office sharing person is looking at an ultrasound for that, and I was
Yeah,
thinking
I know.
do
That
both
seems
things.
so tedious to me to use
Oh
ultrasound
yeah,
for
no,
filler.
I know it's
But
huge.
yeah, but yes, you definitely could. I mean, I was looking at my heart with it. You can do echocardiograms, you can do fast scans, like you can do renal ultrasounds. Yeah, and I checked, of course, the first thing I checked, I'm like looking at my ribs to see if I can see the anatomy for a PEX block, and then I'm looking at
Right.
my abdominal wall to see if I can see the anatomy for a TAP block. So that's a nice option if you're not at facilities that have an ultrasound. They just have to
Yeah.
get the probe covers and plug it right into your cell phone, and you can just have somebody hold it.
Oh, that's what I was going to ask you, how you do it sterilely. So
Yep.
yeah, you just get a probe cover. That's smart.
Yeah.
I have to play around with that.
Yeah, it's nice, and the blocks. I feel like I've been, obviously I haven't had surgery with and without a block, but the recovery room nurses have told me that my patients generally don't need as much narcotic in recovery, so it
Right.
does seem to help. And I find too, I don't have to. So when we do breast augmentations for the lay people, I usually do the implant under the muscle. I think you usually do too.
Yeah.
And the muscle will kind of fight you. It will contract sometimes. So we will often give patients paralytic or have them relaxed so that the muscle doesn't fight us. When I'm doing the PEX blocks, I inject around the pectoral nerve, and I haven't had to have anesthesia paralyze anyone in, I don't even remember when, which is
Oh, that's
nice.
interesting. That is
Yeah.
nice. I don't have them paralyzed either. When I first started and I was still in the Navy, I did, but I think the predictability of whoever was doing your anesthesia was a little harder. And we had a regional anesthesia guy who was dying to do stuff, and I had him come in and do pec blocks for all my breast cases for a while. But again, the consistency, like if you just didn't have enough consistency to see, okay, that makes a difference, it didn't make a difference. But and they would come in and do it at the beginning of the case before the patient went to sleep. So
that's added time. Yeah, I do them right after induction of anesthesia now, and they take me like 5 minutes. So it's worthwhile.
That's cool. And then I do give people some Valium because I feel like that helps as well.
Yeah, for the muscle spasm.
People prefer that, especially on revision odds if I'm exchanging implants or doing something. I feel like people prefer that to the narcotic. Yeah. So,
because it's more of a tight
ultrasound.
Yeah, it's more of a tight sensation from what everyone tells me, and like you feel like you can't quite take a deep breath rather than a true pain.
Yeah, I had a breast augmentation myself, and I did not love the narcotics, but I never have. They make me sick for every surgery I've ever had. And then I did like the Valium because I felt it was like relaxed the spasming. And then honestly, the thing that I felt helped the best with pain afterwards were ice packs. Those were my friend. And for me to say that is a lot. So I tell my patients to do it because I don't like being cold. So my ankle could be swollen and twisted, and I'll be like, I'm good. So I don't like to ice anything because it just makes me cold. But I really felt like that helped a lot.
Did you just do them like up in the armpit where it's really sore?
Actually, just up on top on the chest there. Yeah, and in the armpit a little bit. So, I thought that helped a lot. And then I don't use gabapentin. I don't know if you ever use that.
I do. I give it to everybody now.
Okay.
Yeah, and it seems to help. I always warn them, though, it may make them really sleepy, and if it does, don't take it or just take it a couple times a day. But it helps with the little zinging, shooting nerve pains.
Okay.
Especially, with breast augmentation, the nerves are all on stretch, as Dr. Gallus knows, and I find it helps with that. I do it on my tummy tucks and my facelifts too, and it's pretty well tolerated. I only do 5 days, though.
Okay. Yeah.
Yeah.
And then do you preload it? Give it to them before surgery?
I don't. I haven't been doing a preloading dose. I just give them 300 3 times a day starting the night of surgery.
Oh, okay.
Yeah.
And then what about I think risk factors for having nausea and vomiting after surgery are young and female, and breast surgery. Those are known risk factors. So I tell people to get really hydrated. Is there anything you do to
I don't actually. Yeah, I really don't. I give everybody Zofran for afterward.
Yep.
But I don't. Our anesthesiologists are pretty they always question about post-operative nausea and vomiting if there's a history of motion sickness, and they are generous with the scopolamine patch. They'll often do Tiva, which is total IV anesthesia instead of gas, which can tend to make you a little bit nauseated.
Nice.
Yeah, so they're pretty on the ball. We have one anesthesia group that works at all our hospitals and surgery centers, so it's really, really consistent care, which is nice.
Oh, that's good too. Yeah, there's a couple of different groups in town, so you get a little variety, although most of them kind of use the same things. I don't know that anyone would use Tiva. I guess they might modify it if somebody said, "Oh, I have a history of nausea and vomiting."
Yeah, I mean, I don't know what their exact protocol, but they're very on it. And then, I mean, at least it's a short surgery, hour and a half, hour.
Right. It's not hours of anesthesia you're trying to get undone. Cool. And then I have patients, they wake up in their bra, you wear a button-down shirt, right?
I honestly never even think to mention it to them, but I've never had anyone tell me, hey, you need to tell everyone to wear a button-down shirt. I think they usually wear loose, comfy clothing.
Yeah. I do think, I think it says that in the written post-op instructions I give patients, so they have to get that at the pre-op, and so they know. I have had people show up in T-shirts, and I'm like, how are you gonna get in and out of that? But it'll be a really big stretchy one.
Yeah.
Oh no, this is super comfortable. I'm like, okay. Yeah. As long as you can get it on and off.
Yep. I wrap up with an ACE wrap too. I don't know if you do that at all. I do. I'm trying trying to think when I started. I actually started with my reductions when I switched to superior medial pedicle, and I got a couple of seromas because I don't use drains. I started doing compression with the ACE wrap, and it was just a little bit like no seromas since then. And I liked it for the stabilization and swelling, so I do it on all my breast cases now just for 2 days.
So you leave them in the ACE wrap for 2 days, and then you switch them out to a bra?
Yep. Well, actually put bra and then ACE over it.
Oh, okay.
Yeah, I knew
ACE wrap on in the OR then.
So we sit them up, and what I do is I just have a nurse on each side, and they hold a hand under the shoulder, and the anesthesiologist holds the back of the neck, and it's actually pretty easy.
Oh, okay.
Yeah, we don't lift them very high at all, and I just wrap it up around them. I trained in St. Louis with Dr. Prada, who is really, he does a ton of augs, and at that time, I don't know what he still does. Do you know the big fluffy cotton padding that ortho uses like for bulky splints? They're really thick, fluffy. He would do a whole layer of that and then an ACE wrap. And he's in St. Louis, which is 110 degrees in the summer. And all I could think about was how hot and itchy that must have been. Yeah. So I just do the ACE wrap, and it does help provide a little bit of compression and stabilization. It makes me feel better anyway.
Right. Yeah, I just throw them in a bra. Everybody gets a bra. The only tricky part is that if you get the bra that doesn't fit quite right.
Yes, and then you're like, oh, I measured the band too small, or oh, this is really kind of large. Yeah. That's where I like having the ACE wrap that can kind of cover a multitude of.
For having
it helps.
That. I know what I was going to say about the blocks. There's I'm blanking on her name, but she had emailed me about something else. One of our fellow plastic surgeons who's in San Francisco, and she was redoing our office, and so we were
Dr. Horton
about stuff.
No, yeah,
chairs or something, and she emailed me, and then she's like, "Oh, well, I just do local cases in there. I do breast dogs," and I was like, "Oh, come again? I'm sorry." And she says she does them under sedation, submuscular, and that's where she trained. She learned how to do it, and she does rib blocks and a pec block, and then sedation, and she's able to do the breast dog under sedation. I'm like, okay, that's yeah, right?
I did a subglandular saline implant aug once under local patient request, very long detail. She had some pretty significant pulmonary disease that precluded anesthesia, but otherwise is really, really healthy, and we had a long talk about like what would happen when she needed them out, and I just did them with like basically tumescent and blocks, and she was straight local, and she did great, but I would not recommend that in general.
I feel like if you're going to have sedation, then
might as well.
I don't know, you already have to have somebody there monitoring it, but who knows? It's just interesting, because I think back in the day IV sedation was more common for breast augmentation, but I think it was just unnecessary torture if they weren't doing it right.
Yeah, well, and now most of my patients I think have an LMA, and they don't even have endotracheal. So there's like basically an airway in your throat, but it's not the tube that goes down.
Right,
so
not through your vocal cords. So
yeah,
you're breathing on your own, and you're not paralyzed, and hopefully you don't get a sore throat, all those things. Yeah, so most of the cases are like that under LMA. So yeah, I'm not sure the advantage. It was just an interesting take on breast augmentation.
It makes me want to go back and read Tebbett's articles. I remember reading those in residency. So Dr. Tebbett's is this guy who owns his own surgery center, has like total control over anesthesia and PACU and, you know, what they do and what their protocols are. And he just basically like leaned. He basically did lean on his whole process of how can we make this more efficient? How can we make recovery more efficient? I mean, he was like changing what drugs the anesthetists use, which you can't do in most places unless you are an owner there. And he had people like in the door, out the door in an hour, including surgery and recovery.
What? I do remember though, he had cameras in the OR, and he would videotape, not to videotape the surgery, but to videotape himself and like decide what was
and like
his use.
His motion and like what areas he dissected first, and like whether he used bovie electrocautery or bipolar, and there's a vessel here and a vessel here, and I have to get those. It was amazing. He did like time motion studies, but he also videoed his scrub tech and the anesthetist to like see what it was crazy, like the amazing level of efficiency. I should actually go back and read those. I bet they're even better now that I'm 10 years out of practice.
I remember looking at those too, because he also had a whole system for I remember it was kind of an elaborate system for the judging what size implant would best suit somebody.
Yeah.
And then it always ended up being, 300 cc's much less.
Funny how that worked. Yeah, I just, we have gel sizers. They stuff their bra. It works
Right.
great. Yeah.
Yeah. And we use the Vector too. So yeah, it was interesting. Yeah, I forgot about how, imagine, because the time it takes to do that and then analyze the data and then make one change and then keep at it for one procedure is kind of impressive. But yeah,
It
the
is.
efficiency thing.
I mean, it's amazing. And I also remember from that article, like his patients going out to dinner that night. Like that was a really big thing.
Right.
Look how easy this recovery is.
I feel like we've swung back to, like, you had surgery, why can't you just take a break, right? I feel like as a culture, we're always trying to push, push the boundaries of not resting. Like, just take a few days off and
your body needs that. You need to rest.
Yeah, you had surgery. Go ahead and heal. Don't push yourself. And there is no, like, why do you have to go out to dinner that night? Why do you have to be at work in 2 days? Like, what, if you can afford to not do those things, like, give yourself some rest and, like, take that time to.
I'm like the worst example of that. I had lipo on a Monday and I was doing lipo on Thursday. Although,
right?
You know what?
No,
it was,
absolutely.
Yeah, I was terrible. But, it really was, like, I felt fine. It wasn't bad. But yeah, our patients need rest and they should feel free to take it.
Take the time to pause. No, for sure. I had C-sections, like, operated one day and had a scheduled C-section next. So that's just, if you're like that, that's
being
fine,
a doctor mom. Yeah, but like before the C-section's fine. If you're going to work after the C-section, I would be yelling at you.
Oh, yeah. 2 days later.
Yeah, that would be no bueno. No bueno.
Right.
But yeah, so then, after surgery, you go home. You kind of feel like you've been hit by a truck because of anesthesia. And then I'm usually telling people to, like, take it easy and rest. And I usually recommend take a week off. I don't know what your general recommendation is. Not that you'll need the whole week, but take it.
Right. And I think it depends on what you do. Right now, a lot of people are working from home. So maybe they can scooch by with a few days and then check in for some meetings.
Yeah.
But I've also taken care of ER nurses, and I'm like, take a few days off, and then even when you go back, can you run the desk instead of, the trauma day or something? So,
yeah, I always tell them, like, if somebody crashes and you need to do chest compressions, do them, knowing that maybe we'll get a hematoma and have to go back to the OR. But if you can, like, record the code and have somebody else do chest compressions.
Right. Push the medications to the IV.
And there's so many other roles that don't involve chest compressions.
Right. Yeah.
Yeah, and that's the big thing for the activity restrictions is that hematoma, you have a late bleed a couple weeks out, and then it sucks because you're going back to the operating room to wash out the blood, decrease the infection risk, decrease the capsular contracture risk. And often it's incredibly swollen and painful too, so.
Yeah. No, so I tell people, the first week maybe you're okay because you're self-limiting, but then the second week is the most dangerous because you don't want to go back too soon and do something abrupt and have a bleed.
Yeah.
So yeah, it's those little don't rush back into it. So certainly no chest exercises. I tell everybody no chest stuff for 4 to 6 weeks. So I follow people pretty closely and see how they're doing. So if you're a yoga or a CrossFit person or, bench pressing or whatever. Person,
just go for a walk.
No-goes. Yeah.
Take it easy. Yep.
It's not worth it. And then you're also potentially displacing the implants, which you don't want to do. So
right. Yep. And they do take a little while to settle. They'll be in good position, but they look really full. And a lot of that's swelling. And I think the muscles tend to retract a little bit and bunch up. And that's why we have everybody doing the above the arm stretches just to help those pec muscles settle.
Yeah, I think that helps too. So in terms of post-op things, I don't have people wear a band. Unless I almost never do.
Yeah, I will if they have a little extra swelling or it seems like things are riding a little high, or if they have like a tight lower pole and the skin just needs more stretch, I'll have them wear a band, but not routinely either.
And then what's the other? Oh, and then do you have patients do implant massage at a certain point or no?
I don't routinely. If it's somebody who's had a history of capsular contracture, I might, or if the implants are just taking a little longer to settle, then I may have them do like just some upper pole stretching with one arm and pushing down with the other. But it's very person dependent. In general, I feel like low maintenance is easier.
Yeah, I feel like making it as least complicated for the patient is what everybody wants. It's already overwhelming enough. And there's certainly no studies that have shown implant massage is helpful or not helpful or creates capcon or prevents capsular contracture. So, yeah. And then I did have one patient a long time ago who was so aggressive with her massage that she sort of pushed the implant out of the pocket. So that was, so I was like, let's not, there's everything has its risk. So if I don't think there's anything to gain by, massaging your implant around, then, and there is something to lose if you're too aggressive with it, then I figure no bueno. But if you're right, and people with capcon, it's sometimes a good idea to have them start moving that pocket around a little bit.
Yep. Yeah. My chairman, when I trained, he was a big advocate of do the simplest thing possible to get the job done. And we did a lot of wound care, and there can be like these complicated, we'll change it twice a day with wet to dry. Right. He's like, throw some Vaseline on it, cover it with a gauze, change it the next day. People will actually be able to manage that, and it gets the same result.
Right. Exactly. So if it's not something that you can follow along, then it just doesn't happen. And then you don't know that it's overall, if it's so if you took a look at like women who did massage after breast aug, are they really doing it? Or,
so how do you know if it even works?
Right. So you're not sure if it's working. Yeah. So I see people the next day. Do you have people come into the office the next day? Or?
I don't. I'll have my facelift patients come in the next day, but I have everybody come in a week. I do call them that night and check on them. Mm-hmm. But yeah, I've never been a big next day person. Probably because I operate on Fridays.
Oh, right.
Yeah.
So that makes it a little hard.
It does.
Yeah, I usually make people get up and see me the next day, so I know that they're up and moving. And then I do see them the following week, and then I start stretching it out a little bit after that. Yeah. I do have people come back first. I laser the scar with a fractionated CO2 laser.
Oh, nice.
So, yeah, at 1 month, 2 months, and 3 months. And it's nice because then it gives me like kind of a schedule for when patients are going to come back and see me. They often do come back, and then I can see how, the progress and see how things are going. So I really like that for retention. Otherwise, people sometimes, have surgery and then you never see them.
Don't show them. Yeah, my patients are a little bit more, like they tend to follow up right up till their 6-month appointment. I like to see them every year or two to check in, and now that I have my ultrasound, I can check implant integrity. So they don't always follow up for that, but people are really pretty good about coming in for their 3-month and 6-month with me.
Oh, that's good.
Yeah, I do fractionated laser if we see some raised up, but I don't do it routinely usually.
Nice. Yeah. I feel like it helps, and we can handle the volume, although some days I feel like that's what I'm doing a lot of. But as soon as I have an RN, hopefully Erin will be able to do some of those as well. So, yeah, but it's nice. It just gives me a touch point for like how things are going overall. Instead of we'll see you at 3 months. But,
absolutely.
Most people do really well, and then you can see the progression as the swelling goes down.
Yeah. You are freezing. I wonder if the internet is going out. All right. We'll see if Dr. Gallus comes back so we can set up our next IG Live and pick a topic. I wonder if my internet's going out. No, mine looks good. All right, guys. In the comments, let me know if you have other topics that you want to hear about. I know Erin has a strong following on here. If there's other topics, I know we've talked about AUG a couple of times. Oh, here we go. She's coming in on another account. So we'll see.
Okay.
Oh, hey.
My connection's cutting in. So,
no
but
worries.
Now I can actually see you. I've been talking to you like a circle. I should have done that earlier. Hi.
Yeah, I'm like in this. Rhinoplasty.
Trying to participate.
So. Oh, nice. I was asking if anyone had topics. I don't actually do rhinoplasty. Do you do rhinoplasty?
No.
So that would probably be a terrible topic for us.
Sorry. We could talk about, do you ever do liquid rhinoplasty? Let's talk about filler.
It's something I offer. I don't do a lot of it, certainly.
Okay.
I think it's a neat topic, but it's often kind of limited. But yeah.
Somebody mentioned breast lift, which we could totally talk about. My sister's a boy.
Yeah, the noses are very tricky. You need to do a lot of them.
Yeah.
I did not do a lot of them where I trained. I could probably count on one hand the number of noses we did.
Mm-hmm. Yeah, you need to do that. All right. So breast
Yeah,
lift
breast
it is.
lift.
Okay. Yeah,
Always
we can talk
fun.
about that. And I think we can talk about the difference between a lift and a reduction because that comes up
Yeah,
all the time.
absolutely. And we can talk about Galliflex too. I've been using that
Oh,
more.
yeah.
And it's fun.
Cool. Yeah,
Yes.
definitely.
I've decided
Especially
I will
California.
personally use Galliflex when I get my lift
Oh, when
done.
you get your
So,
lift.
yeah,
Okay.
I'll be flying out to San Diego to see you. That's kind of a long flight.
That'll be great.
Yeah. All right. So we'll
I
talk
will
about
let you
lift
come in
next
the
time.
next day.
That's okay. That would probably work really well because I'll be flying back to Cleveland.
Right.
Can FaceTime follow up. I've done that with people. I'm
Mm-hmm,
like, hold
totally.
the phone by your belly button. Okay, that looks pretty good.
Yeah. I know my patients that do that and they're like, okay, just 1 second. I got to get into the bathroom and shut the doors.
Yeah, or they're like at work. They're like, hold on, let me shut the office door. It's awesome.
Okay, so breast lift it is. And,
Cool. We'll meet at
so
your
in
place.
2 weeks from now, I will be in Hawaii. So
Oh my
we'll
gosh, I hate you a little bit.
kick it a week.
Should we do 3 weeks? Yeah, of course.
Yeah.
Wow,
It'll go by
super
fast.
jealous.
I know,
Okay.
sorry.
It's probably an easier flight when you live in California. It's
It
really a
is.
long trip for us in Cleveland.
Yeah.
Yeah.
Yeah, it definitely is. Although it's still 5 hours, so.
Oh my gosh. Yeah, I guess it really is
I know.
not
The first time I
close.
flew from San Diego to Hawaii, I was like, wait, what? I thought we're like, isn't it just like over
Yeah.
there?
Yeah, so for me it'd be like 4 hours to get to San Diego and then 5 hours. No
Yeah,
wonder I
that's
haven't gone to Hawaii.
it's why we don't go to the Bahamas.
Right. Whereas we're like going on a cruise in March. It'll be lovely.
Oh,
Western
see?
Caribbean. See?
Nice.
Yeah. It's
Yep.
okay.
All right.
We'll trade
There's
off.
upside.
Yeah.
Okay.
All right. So
Um,
3 weeks it is.
Yep. Have a good night.
You
Bye.
too.
Thanks everybody for joining.
Yes. Thank you.